Put it here. And then.
Today on adverse drug reactions, given by Lori Navarro. We appreciate her coming back to do this for us.
You're welcome.
So everybody, welcome Lori.
Hi. I think for everybody on this side that sees me, I might just sit because juggling the keyboard, and can everybody hear and see me that way too? Okay.
That's fine.
Okay, great. And can you guys hear me over there okay, or do I need to be louder?
You're good.
You're good? Okay, great. So what we're gonna, I have to adjust a mic just for everybody before. Does that work? Can you hear me better? Okay. All right. So what we're going to talk about today is adverse drug reactions, and mainly just focusing on those medications that you guys use at this organization. So any of the antipsychotics, the antidepressants, drug reactions that you can see from those agents. So that's what we'll discuss today. First thing is serotonin. We use a lot of antidepressants in this organization. Mainly the SSRIs, which are blocking the reuptake of serotonin, so you have more serotonin in your system. And also the TCAs, the tricyclic antidepressants, also are blocking the reuptake of serotonin and norepinephrine. So again, you're having increased serotonin in your system. So that's why we want to first look at serotonin and what it does in the body. First thing that it's going to affect is your CNS. And one of the main things that it does is it'll modulate your attention, your behavior, and thermal regulation. So this can affect anything as far as your sleep, your arousal, your happiness, your memory, your appetite, and some learning and memory, like I mentioned before. So all this is modulated not only by serotonin, but it's one of the many factors in your brain that's affecting CNS systems. The next thing that it can affect is your peripheral systems. And probably 80% of serotonin in your periphery is in your GI system. And this will work to modulate your gastrointestinal motility, which will be your how quickly your GI is moving. So it will modulate things like your nausea, your vomiting, your diarrhea. A lot of the agents that we use to work on this works on serotonin. So. Other things that it can do in your periphery are vasoconstriction, and then also uterine contractions and bronchoconstriction. Basically, serotonin in your periphery works a lot like a vasoconstrictor, so that's why you see those type of reactions as well. And the final thing, which I just learned this not too long ago myself, is that you have serotonin on your platelets. And what this does is when you release serotonin in your platelets, it causes them to aggregate or clot together. So serotonin is one of the major reasons for clotting in your platelets as well. And so once I had read, and how I learned this was the package insert for, I think, Prozac. I was looking at once, and it said that you could have an increased risk of GI bleed. I'm like, why in the world would that be? It's probably because of your platelets. And it's going to decrease when you're decreasing reuptake. You're decreasing the amount of serotonin that's taken up into those platelets and how sticky they are and how well they'll clot. So. Interesting little fact. All right, so looking at your serotonin system, this is just the basis of how your synapses and your neurons work. So you've probably all seen pictures of this a zillion times. And how you want to look at it is they always kind of flow top to bottom or from upward to downward when looking at synapses. It's not necessarily in your body that they're going to be set up upward or downward, but that's kind of the thought process whenever you're looking at these. And with this, you have L-tryptophan, or tryptophan, like when you hear people talk about turkey, that it has tryptophan and amino acid in it. This is what's converted into serotonin in your system. So in that top, what's called your presynapse, you have the conversion of the tryptophan into serotonin, and then it's released into that intrasynaptic space so you have free serotonin in between those two neurons. So you see those little green dots are all the free serotonin. And with this, then, the little, orangey yellow blob that you see off to your right-hand side is what's called a serotonin reuptake. So what that does is your body regulates really carefully how much serotonin you have between these two neurons. And so your body naturally reuptakes the serotonin if there's too much free serotonin. And that's why we have the SSRIs, because they are serotonin reuptake inhibitors. So it's blocking that little mechanism of action to take up the serotonin, therefore you'll have more serotonin in your system, or more free serotonin. And then one other piece of that is if you look up at the top, there's one called monoamine oxidase, and those are MAOIs, work at this point. So your Nardil, Parnate, those type of agents. What this does is that's working to metabolize all the serotonin that's taken up into your system. So when it's reuptake, it'll grab a hold of that serotonin, metabolize it, and get it out of your system. So what the MAOIs do is they'll work to disinhibit that, therefore you won't metabolize your serotonin, therefore you'll have more free serotonin in your system. Does that make sense to everybody so far? Okay. So with the next piece of this, when you're working top to bottom, we've kind of talked about how serotonin flows down and is in your intersynaptic space. And then the bottom part is the postsynaptic terminal, or your neuron. And what those little pieces of serotonin do is they'll bind to a receptor, which is the little red piece that you see in that bottom. And when it binds to that receptor, that's when you see all the effects that you want to see from serotonin, which are like your mood regulation, or if it's in your GI, it'll affect the motility of your gut. So anytime that little serotonin binds to receptor, then you'll see the effects of the serotonin. Make sense so far? Okay. So looking at drugs associated with serotonin syndrome, this is actually an article from the New England Journal of Medicine that kind of looked at a combination of multiple different articles and looked at all of the agents that were listed as causing serotonin syndrome. So you can see there is a large list here, and this probably doesn't comprise everything that you're going to see cause a serotonin type syndrome. It's not an all-inclusive list. It's a pretty extensive list, but there could be other agents that are left off that just weren't in the New England Journal of Medicine article, so I just included those so far. But just to touch on some of these, we kind of already talked about this, but your SSRIs, again, are increasing the amount of free serotonin that you have in that intrasynaptic space, so you have more free serotonin. Your antidepressants are also mostly working to either bind to a serotonin receptor or cause the decrease in, cause inhibition of reuptake. So again, you have more free serotonin, as well as working on other receptors. That's why they're not in the SSRI group. The MAOIs, again, those are inhibitors. So we're inhibiting the metabolism of serotonin in the system, therefore you have more free serotonin. With the analgesics, they actually are working as weak SSRIs themselves. So they're actually causing a little bit more serotonin to be free in the system. Antiemetics are blocking the serotonin receptors, so therefore you might have drug interactions that would cause more serotonin in your system because they're blocking receptors. And the one of interest on there that we kind of always forget is Reglan, or metoclopramide. And with this one, it affects multiple different receptors. It's affecting dopamine, it's affecting serotonin, and it's affecting acetylcholine. So you're touching all those receptors with Reglan. So it's one that we really need to keep in the back of our heads, as it's a drug-drug interaction with most of the meds that we use here at this campus. Sorry? Which ones? Dopamine, acetylcholine, and serotonin. Mm-hmm. And that's why it's working as a good antiemetic, because of the serotonin in your gut. It's working to block that, and therefore you might decrease motility. So if you're having vomiting or diarrhea, it might help to, it doesn't, I guess, really help with diarrhea, but it does help with vomiting. So, the migraine agents are stimulating serotonin, so therefore you'll have more serotonin in your system. A bariatric agent Meridia actually works as an SSRI itself, like minimally. The antibiotics that you see listed there are working as MAOIs, so they have that potential as well. So it's something that we're usually really careful of anytime we start somebody on linezolid in the hospital for infections. We're looking to see if they've been on an SSRI type agent. Cold preparations can cause drug interactions that disinhibit the metabolism of serotonin. Drugs of abuse, they're either acting as an SSRI or just increasing serotonin in general. So this isn't probably an all-encompassing list, but it's a good start of ones that you might see. Dietary, a lot of those are working as an SSRI, and the other agents are usually working as drug interactions that you see listed there that can cause more serotonin in the system. So drug interactions, this again is from that New England Journal of Medicine article, and this is from all the case reports that they've had that they could find in the literature. These are the ones that, when used together, and the boxes kind of show the ones that have been used together, can cause serotonin syndrome, or their case reports of serotonin syndrome with these agents. So again, it could be that both of them are working as SSRIs. There's a drug interaction that inhibits the metabolism of one versus the other. So a whole host of different drug interactions that you need to be careful of. I'm not going to go through each and every one of them. So, as far as serotonin syndrome, it's a classic triad that you have mental status changes, that you have autonomic hyperactivity, and we'll go through each of these in depthly so you understand what each of those mean in a little bit, and also neuromuscular abnormalities. And so basically, if you're looking for serotonin syndrome, you want to see all three of these happening. It might be one's more mild or one's more severe, but you'll usually see the classic triad. So looking at each individual system, autonomic nervous system is something that's, in essence, you want to think of subconscious things that are happening in your body. So things like your breathing, things like your blood pressure, things like your temperature control are all things that are going to be in your autonomic system. So you're going to have things like diaphoresis that begin to occur because what's going to happen is you're going to have so much serotonin in your system, it's going to augment everything that's happening in your autonomic nervous system. So it's going to increase, in essence, everything. So you're going to see increases like hypertension, tachycardia, diarrhea, shivering, all those type of symptoms. In your neuromotor system, you're going to see things that basically hyperexcitability of your muscles. So you're seeing things like hyperreflexia, myoclonus, which is or actually it's like a contraction and relaxation of your muscles continuously. So it's kind of like almost like a seizure where you see constant clenching of your muscles. And again, everything that you see here is just increases in your muscle activity. Trismus is that your jaw it's lockjaw is kind of what that's referred to, so your mouth is closed. Ocular clonus is that you're going to see slow horizontal movements of your eyes. It's not necessarily nystagmus, but it's like a slower horizontal movement of the eye. Cognitive and behavior-wise, again, it's excitability, and so you're going to see things like confusion, agitation, hypomania, hallucinations, because again, you have too much serotonin in your system. So this is a nice little picture example of just like looking at the body of everything that you can see that's going on potentially with somebody that has serotonin syndrome. And the first one is mydriasis, which is pupil dilation. So you'll see that their pupils are dilated. You see that they have the diaphoresis, they're agitated, they have increased bowel sounds or diarrhea. The other big thing with serotonin syndrome is you have all that hyperreflexia that's going on, or tremors, and the clonus where you're having the muscle contractions. It's generally seen in your lower extremities, much more so than your upper extremities. You can see it everywhere, but it's usually more pronounced in your legs. And this is kind of just showing you the scale of presentation of serotonin. So you can have anything from mild symptoms where you have just akathisia where you're feeling restless and jittery, you're a little bit altered mentally, to the full scale where you're going to have hyperthermia and where you have the muscle hypertonicity. This is where it's becoming severe and you're probably in an ICU type setting to deal with all the blood pressure issues, the hypothermia. There's going to be extreme measures that are taken with cooling blankets and those type of things to get the temperature down quickly and right away. And it can become very life-threatening if not taken care of and getting those agents off as quickly as we can. So as far as diagnosis, and this might be a little bit hard to read on here, but I'll just kind of walk through what it says for you. First one is, the biggest thing with this is, did you have a serotonin agent in your system? That is the biggest question you have to ask first, because when they go through the checklist of diagnostics, there's certain checklists that you go through. First, if you have somebody with these type of symptoms, did they have a serotonin type agent in their system, or 2 serotonin agents in their system that could be causing a drug interaction? And if you answer no, you pretty much have ruled out serotonin syndrome, for the most part, I guess you could say. And if you've answered yes, with that, you then look and see if they have any of one of these criteria that are listed. And they are tremor and hyperreflexia. So that's one. You can have spontaneous clonus, or the muscle contractions, muscle rigidity, and a temperature greater than 38, which is 100.4, and either ocular clonus or inducible clonus. So that's number 3 window. Number 4 is ocular clonus and either agitation and diaphoresis. And the final one is inducible clonus and either agitation or diaphoresis. So if you have had a serotonin agent and you have any one of this grouping, you can go down the path of serotonin syndrome for this patient. So when looking at the management of serotonin syndrome, the very first thing that you want to do is remove that agent. Get that agent off. Your body will, without those agents on board, will start to metabolize that serotonin in its syndrome, in its synapse. It'll start to reuptake that serotonin again to get rid of all that free serotonin. So usually when you pull off the serotonin agent, you have resolution of your symptoms within 24 hours. This is usually, if you have something like Prozac that's causing this that has a super long half-life, it might take much longer for these symptoms to fully go away. It might not be as severe once you get it off, but it might take longer for it to resolve. The next piece of this is you want to do supportive care. That's the main thing that you're doing for these patients other than taking off the serotonin agent, is you want to make sure that they have IV fluids on board. This will help with their blood pressure. It can help with their temperature. It will help with when you have muscle rigidity and from that contraction that's going on continuously, you can have muscle breakdown and you'll have buildup of things like lactic acid and creatinine kinase, and you could have problems with your kidneys and different things come up if you continue to have those type of reactions without fluids. And then the big thing is just monitoring vital signs, so making sure that their blood pressure is stable, making sure that their temperatures are coming down, helping them with any agitation that they're having from mental status. And you can treat that with benzodiazepines. There's no drug interaction that's going to occur with benzodiazepines, so it's good for agitation. One of the biggest things, though, that they do talk about in the literature is that you should not have physical restraints on these patients, because if you think about it, their muscles are continuously contracting. And if you make it isotonic as they're continuously contracting, they'll build up lactic acid, and you can throw somebody into metabolic acidosis by having that go on. So you do not want to use physical restraints. You, in essence, they say use chemical restraints, so use a benzodiazepine. The next piece that you can use, if taking the agent off board and also they're getting more to those life-threatening stages, is using an antagonist or a blocker of serotonin. And these work on the 5-HT2A. It's cyproheptadine is the agent that is the blocker. We sometimes use this in eating disorder as well, but it's used for serotonin syndrome. I've actually only ever seen it used once in an ICU that I was in years ago. We had a patient that came in with serotonin, and we did give him this agent. Usually what you do is you give them a loading dose of 12 milligrams, and then you just keep giving them 2 milligrams every 2 hours while they have symptoms until you start to see them resolve. And then if it's a longer agent, and depending on how the patient's responding, you might need to have maintenance dosing. So if it's somebody that was on, again, Prozac with that super long half-life, you can potentially have them on the maintenance therapy. Another thing is, we kind of talked about this, is you want to make sure that you maintain blood pressure control, and it's can vary greatly. You can go from having 1 minute hypertension to the next minute having hypotension. So it's just something that you need to make sure that you're regulating. And then hyperthermia, when it gets into those really extreme cases, you want to eliminate any excess muscle activity. And so sometimes if somebody is in an ICU, it's really life-threatening. They continue without the agent on board and with cyproheptadine to have those muscle contractions. They might actually induce a coma in somebody where they will give them the muscular blockers. So those type of agents will be given, but you'll also be ventilated and you'll be sedated prior to getting those agents. And what they'll do is it just will disallow any contracting of your muscles. So therefore, hopefully it'll bring your temperature down. So does anybody have questions before I go on?
That screen, that was pretty much what takes place in the next few years.
Yeah. Pretty much, you're at that, you know how I had that continuum up, that's the more severe cases. If somebody was just having mild cases where they were a little bit, had some tremors, presenting to their physician office or presenting to you guys, having tremors or being a little bit confused, you're probably just gonna remove the agent and see if that resolves within 24 hours. They might potentially decide to do a cyproheptadine to see if that helps as well. But no, all those other are going to be an ICU type patient. So this case is a serotonin case, and this is Libby. And this is probably the most well-known case of serotonin. It's talked about in multiple cases of the literature, and I'll explain more why after we talk about it. This was a college freshman that was admitted to the ED with flu-like symptoms. She was taking flunarizine, which is MAOI inhibitor. And she was also using cocaine, which the family who brought her in was unaware of, and so were the MDs that were taking care of her, which were residents in an ER one, let's say, weekend that she came in. And she was hydrated, and she was having strange jerking motions. So she was almost having the myoclonus, where she was having those muscle contracting, and so they gave her meperidine, which acts as an SSRI, and therefore reacting with the phenelazine and also with the cocaine, because cocaine can increase serotonin in your system. She became more agitated. She was put in physical restraints, which again, we said don't do that because you can have lactic acidosis and actually your temperature can probably continue to go up. And her temperature reached 107 degrees, and she had cardiac arrest before her temperature could be brought down. So as I talked about, it was the combination of all those agents without knowing that she had serotonin syndrome that was probably causing the severity of the serotonin syndrome that was occurring in her and let her temperatures get up to 107 degrees. The background behind this is her dad was a lawyer and was a columnist for the New York Times. So this became a very well-known case. And they took it to, I think, Senate or Congress and had the Libby Zion law passed, because part of this was it was 2 residents that were taking care of tons of patients on their own on a weekend. They were on for hours upon hours. So this case is actually what instituted that residents can only work 80-hour work weeks. So that's where this came from. And I think there's a whole host of things that go into that law. It might limit the number of patients too, I'm not sure. But definitely it created the 80-hour work week for residents. So a pretty well-known case. And I think one of the first where they really definitely started to think of serotonin syndrome, working with, I think, the drug-drug interaction component that can happen with it. All right, any questions on serotonin syndrome before I move on? No? Okay. Next piece of this is the dopamine pathways, and there are 4 major dopamine pathways in your brain. There are many dopamine pathways, but these are the four major. It's the mesolimbic, the mesocortical, the nigrostriatal, and the tuberoindofibular tract. So those are the four pathways. We'll talk about them a little bit more in depth so you understand how it's working. Again, this is just like serotonin, and just to show how it flows, this could all be in the same neuron, by the way. Serotonin and dopamine, they're not each their own neuron, but usually in pictures they show it this way. So you have your dopamine flowing down your presynaptic. It's released into that free space as those little triangles. And then you see the little orange like columns at the bottom are your dopamine receptors. So the dopamine is binding to those dopamine receptors to have the potential activity that you want in those different pathways. So these different pathways are the reason why we started using antipsychotic agents, and which are dopamine blocking agents. Main reason is when you have hyperactivity in your mesolimbic system, you have psychosis, you have hallucinations, you have delusions. So that's the main purpose behind antipsychotics, is that they are dopamine blockers. This is a hyper state. If we block those receptors, we'll hopefully limit the amount of hallucinations and delusions that you have with a person with psychosis. The next pathway, mesocortical, is the cognitive function, and this is thought to be why we have negative symptoms in a patient with schizophrenia, that they have the lack of energy, the anhedonia that happens. So this is a hypo system, and that's why antipsychotic agents don't always necessarily work great on those symptoms, because we don't really necessarily need blockade in that pathway. Nigrostriatal is the one that controls movement, so that's probably the main one that we're going to focus on today, because that's how we see side effects from antipsychotics, is that we're disrupting the nigrostriatal pathway of dopamine. And then the final one is the tuberoindofibular, which inhibits prolactin release, and this is can work on a whole host of hormones in your body. We'll talk about it a little bit more later too. So for dopamine, like I had talked about, these are D2 receptor blockers or antagonists. So we're blocking the dopamine in the brain. So by doing this and by blocking the nigrostriatal pathway, we cause disruption in movement, and therefore we can have the extrapyramidal symptoms that we see with antipsychotics. And what you, how you think of this is that you have like a teeter-totter or a balance of dopamine and acetylcholine. And with the antipsychotic agents, you decrease the amount of dopamine you have, and therefore the balance falls, and you have higher levels. It's not like just in the balance, you'll have higher levels of acetylcholine. And it's thought that when you have this disruption of the two, that's when you see the interference with coordination and movement in these patients. So as far as extrapyramidal syndromes that you can experience, the main one is dystonias. And this is, as it says here, a muscle contraction that can cause twisting and repetitive movements and abnormal postures. So you can see things such as protrusion of the tongue, and with this, you it's not necessarily swollen, but the patient will tell you it feels like their tongue is swollen and it'll protrude from the mouth. So that's one of the symptoms you can see with dystonia. Their jaw can be forced open, or with trismus, it's forced closed. So some disruption of the movement of their jaw. Facial grimacing, and then also you can have a whole muscle group contract together, and this will be things like torticollis, which is where your neck will turn to one side and stay locked in that position. Laryngospasms are your laryngeal cords will spasm, and it can cause problems with your breathing. It can cause problems with your speech, and from the literature that I've read, it's one of the most frightening because you're having a hard time breathing. The next one is the oculogeric crisis, which is where your eyes will deviate upward and to the side and sustained in that position. So your eyes are kind of rolled up into your head and stuck that way. Physiotonic is when you have your back will arch, I can't, let me look here. Your upper limbs will flex, your lower limbs will extend. So it's basically like the whole body just flexes in a weird contraction and becomes rigid and will sustain that way. And the final one is the thoracic pelvic crisis, which is your pelvis, your lower like hips, your abdominal muscles will all contract in a weird kind of spasm, and you can have problems ambulating once that occurs as well. The next one is Parkinsonism, which is very similar, and if you know anything about Parkinson's, it's actually very similar to what's happening with these antipsychotic agents, is that your nigrostriatal pathway of dopamine in patients with Parkinson, it actually degenerates, and that's what causes Parkinson's. So there's that disruption of dopamine and acetylcholine in Parkinson's. So that's why we see similar symptoms, or pseudoparkinsonism, with an antipsychotic. So you see the bradykinesis, which is slow to start movements, and also rigidity, the cogwheeling that we see in patients, which is you feel that like catch in their arms when you move them, and postural instability, so very similar to Parkinson's because we're affecting the same pathway. The next piece is akathisia, which is a restlessness that can occur in the body. So you don't necessarily have a tremor per se or a spasm of your muscles, but the patient will tell you that they feel like they cannot sit still. They will, like if they're standing still, they'll march in place. If they're sitting in their chair, they'll rock, or they might have to walk around the room. So that's what you're seeing with akathisia. So these are the antipsychotic agents and a listing of the degree of EPS that you can see with each of these agents. The top ones that you see are the first generation antipsychotics. And with this, basically you think of the degree of dopamine affinity that that agent has. So the more affinity it has to that dopamine receptors, which the first generation antipsychotics have more affinity, the more degree of EPS. So that's kind of how you see the breakdown. And if you look at the bottom, that's the atypical antipsychotics. They have less because they have a little less dopamine, and they're also working on serotonin. So they're not like the first generation agents that only work on dopamine. Questions on that so far? No? Okay. So with EPS management, you want to think again of that balance where we have dopamine and acetylcholine. And as your dopamine falls down, the thought process is, let's use an anticholinergic agent so that before we drop that acetylcholine level down, we might bring them back in balance and cause a resolution of those symptoms. So that's the thought behind using the benzotropine or the cogentin, is that you're trying to bring that balance back together to bring back the coordination of muscle movement. The reason why we use Benadryl or diphenhydramine is it's an anticholinergic agent as well. It also hits the histamine receptors, but it works basically like a cogentin will work in the patient. And then the final piece is a lot of times we give patients lorazepam because, as any of you have probably experienced with a patient, it's extremely anxiety-ridden or stressful to have this happen to you. So just helping the patient by giving them lorazepam is beneficial.
I was told that sometimes the lorazepam can actually mask it and not really help it.
Yeah, it's not going to help because it's working on what's called the GABA receptor. So it's not going to affect the dopamine or the acetylcholine at all. And potentially, yeah, you have muscle relaxation with that. So potentially it could mask it. And that's you might have to give somebody a repeat dose as well. But yeah, it's not going to treat. It's just helping with the anxiety of the symptom. And then to explain, those are the management in this piece is management of a dystonic type reaction, so the dystonias and the Parkinson. With akathisia, it's a little different. Where you don't have the actual contracting going on, they actually say to lower the dose of the agent or use a less potent agent like clozapine, as you saw on that grid. It's listed as almost a 0 because it has lower affinity to the dopamine receptor. And then the other thing that they have found through research is that beta blockers help these patients. I don't think they know necessarily the mechanism of how this works, but it definitely does work for patients. And they usually start a little lower just to watch blood pressure and then titrate it up as needed for the patient. Anticholinergics can be used and benzodiazepines can be used, but they're not necessarily always that helpful with an akathisia. And if the dose is where it is, you might have to use these things long-term to make it beneficial, and you don't necessarily want to have somebody on long-term benzodiazepines or anticholinergics if you can not have them on them. One downfall is, again, no medication has no side effects associated with it. So the anticholinergics do help with the symptoms of EPS, but they also have their own list of symptoms or side effects that they can cause. And the biggest way that I was taught, and probably most pharmacists were taught in pharmacy school, is that it's considered anti-sludge. So you're working with, and each letter stands for the first letter. So salivation is the S, and when an anticholinergic is given, you decrease salivation, so you have dry mouth. The next one is L, which is lacrimation. That's decreased, you'll have dry eyes. U is decreased urination, so therefore you'll have urinary retention. D is defecation. You have decreases of that, you'll have constipation. G is for your GI. Again, you'll have constipation potentially. And E is emesis. And cholinergic agents can cause somebody to vomit and have emesis. If you give an anticholinergic, it'll stop it. Questions on those? The only other, I guess, piece of this is the central nervous system effects, is that after somebody's given one of these agents, just be prepared that they're probably going to be pretty sedated. And if they have underlying confusion or psychosis, you might exacerbate that. So just be aware when using these agents, it could cause those side effects. So EPS cases. An adult patient was started on loxapine, 5 milligrams BID on the 20th. On the 24th, they presented with rigid muscles in the neck, back, legs, and were unable to walk without assistance. So which would these be in the grouping of that we talked about before? It's torticopelvic, because you have the trunk, the abdominal muscles, the hips that are being contracted. Patient was given Cogentin 2 milligrams times 1 and lorazepam 1 milligram times 1, and all symptoms resolved within 20 minutes. This is a case that happened at Rogers. I pulled this from your ADR reports that come in, so this is an actual case from Rogers. Next case is also an actual case from Rogers. It's an adolescent patient that was started on risperidol, 0.5 milligrams TID on the 9th. Compazine was started PRN for nausea on the 10th. By the 11th at 18:15, the patient began to experience mild cog-willing, both arms. And MD was contacted and was told to, nurse was told to hold the risperidol because patient was kind of experiencing symptoms of being tired and sedated. Within, I think, 45 minutes, patient began to develop jaw tightness and excessive drooling. And they were given Cogentin 1 milligram and then put on scheduled Cogentin, and all the EPS symptoms resolved. And does anybody see the problem in this patient from the top line?
It was the Compazine versus the risperidol.
Right, so what Compazine does is it is a dopamine 2 receptor blocker. Risperidol is a dopamine 2 receptor blocker. So this was a drug interaction that likely caused the patient to have EPS symptoms because we were blocking too much dopamine. That's another thing I forgot to say, is that the thought process behind that is when you have EPS symptoms, you are likely occupying or blocking 80% of the dopamine receptors in the system. So you're at a high level when you start to, of your dopamine receptors, when you start to see these symptoms. So the two together, both being blockers, probably causes patient to get to the 80% or above. Final case is just a typical antipsychotic case that was a 34-year-old man with schizophrenia who was started on risperidol. Within a few months, he and his mother noticed that he had upper and lower torso extremity tremor and profound restlessness, especially of the legs. Symptoms began to worsen, and when he was taken off risperidol and put on olanzapine. The tremor resolved, but the restlessness persisted. It got to the point where he was unable to sit through 15 minutes of medication management. He was pacing in his room. He would only be relieved of this when he was sleeping. He couldn't sit still for more than a few minutes. Sometimes his mother said he was walking so much he was causing his feet to blister and bleed. So what jumps out at you with this case is the type of EPS that we're seeing? Yep, akathisia. So in this scenario, and this isn't a case from Rogers, I didn't have any cases from Rogers, but what we would do is probably lessen that dose or consider putting him on an agent that has less dopamine affinity, and also potentially giving him beta blocker to relieve those symptoms. And if he remains really irritable, agitated, he might even benefit from a benzodiazepine short term until the symptoms could get under control. All right, questions on EPS management? All right. I might have to start going a little bit quickly here with the rest of this to get through all of them, but we'll do the best we can. Tardive dyskinesia, again, is the result of antipsychotics long term. And it is usually seen after at least 4 weeks of antipsychotic use, and it persists for at least 4 weeks, and also that you see it after starting the agent or discontinuing an agent for 4 weeks. And it's most common in your jaw and oral areas is where you see it predominantly. So I'm not going to read this. It was hard to summarize. These are all theories of how tardive dyskinesia comes, and they are still uncertain of the exact mechanism, so it's all still theories. So with this, these are the theories. I'll give it to you quickly, is that the first one is increased sensitivity in your nigrostriatal pathway. So potentially you're more sensitive to dopamine. The next one, which is probably the one that most people lean toward, is that you have upregulation of your dopamine receptors. So I think I have where you see your little orange columns down there, after long-term use of an agent, and this happens with other medications like opioids as well, those little orange columns, they'll double, triple, quadruple. As your body can tell it's not getting dopamine and it's being blocked, it'll try to supplement that by creating more and more receptors. So that's another thought process, is that you have multiple receptors, therefore your antipsychotic can't block all of them. And so you have dopamine hitting those receptors, especially in the nigrostriatal pathway that affects your movement. Next one is that you can develop sensitivity. So the first one is that you are born with sensitivity to dopamine. The other one is that long-term use can cause you to develop sensitivity to dopamine. Next is that you have exaggerated response to dopamine when its blockade is just decreased. So if you decrease the dose just by a little bit, and those receptors can now get dopamine, every response that they have to that dopamine will be exaggerated. So that's a thought process. And also the final one is that in your, and this one's a little bit more complicated, but in your basal ganglia, it controls movement. And if you have suppression of this long term through this thalamocortical pathway, you can suppress unwanted movement. So the jerking that you see with tardive dyskinesia, it would be an unwanted movement and you're unable to suppress it. So prevention and management of tardive dyskinesia is the biggest thing, early detection. If you start to see somebody that's on an antipsychotic that has any type of symptoms that would be seen as tardive dyskinesia, the quicker you can stop the medication for them, the better, and the more likely that it won't be irreversible damage. The next piece of this, and it's not really, I think, plausible, but that you should avoid all treatment with antipsychotics and or Reglan, because Reglan, as we spoke about, is a D2 receptor blocker and actually fairly potent. And patients that are on long-term Reglan, there's FDA MedWatch that came out last year, that they see more and more cases of tardive dyskinesia, people on long-term Ritalin, so just as much as the antipsychotics. So the biggest thing is discontinuation of the agent once you see the tardive dyskinesia, if you can. A lot of these patients are treatment resistant, schizophrenics that need to be on some sort of agent to be able to function in the environment. So the other thing is if they were on the first generation agent, switch them to a second. If they're already on atypicals, consider switching them to a clozapine or quetiapine because they're the ones that are seen to be the lowest potential and actually can work to help the tardive dyskinesia once it is started. So once you pull the agent, that's the offending agent, you usually see symptoms subside within several weeks, and it's not proven at this point in time through multiple clinical trials whether it's actually effective by pulling away the agent, that all this theories that we've talked about have reversed themselves. So there may or may not be a good treatment for this in essence. Once you pull away the agent, you can see new onset dyskinesias, and these usually subside on their own in several weeks to a month without any treatment. So you'll see them crop up, but usually they'll slowly fade on their own, which in this scenario with somebody with tardive dyskinesia, how can you tell the difference? I don't really know, to be honest with you, but they do say that those will dissipate after a few weeks. And then the final piece is once you've had tardive dyskinesia develop, you have more potential for it to happen again with another agent. So that's a downfall for these patients. Like we said, they are a schizophrenic that needs these medications to function. So it's just working to find the agent that will work for them. So there's multiple different treatments out there that are in theory or being looked at in research. Not all have good clinical data at this time. So benzodiazepines are one of those treatments. They have seen through case reports that they think people have depleted GABA, which is, GABA works as an inhibitory agent to decrease the amount of excitability in your body. So it decreases CNS, that's why you get sleepy, decreases your muscles. So it's thought that it can improve some of the abnormal movement scores in some of the cases and some of the trials that they've seen. And clonazepam is the usual agent just because it's a long-acting agent that they use for these patients. Botox injections is another one that has limited evidence so far. It's mainly used for the reactions that are contained or limited to a small area, because what it does is it is a neuromuscular blocker in essence, and it'll cause those muscles to relax, and then therefore you won't have the continuous movements and contractions. So it's limited to small areas. And the downfall of it too is that, especially the, I don't know how exactly to say it, but blepharospasm is your contraction of your eyelid, so continuous blinking. Putting that around your eye, you might get disruption of other muscles around your eye as well, so it's kind of a downfall. The tetrabenzazine and reserpine are dopamine depleters. So again, it's something that's potentially too sensitive to dopamine. So if you deplete that, these might be beneficial. But again, effectiveness has been limited in trials. Anticholinergics are another agent that potentially have been looked at, but most times they're ineffective for patients that might actually exacerbate symptoms. But in those patients that you've tried everything else, it's worth trying to see if it's helpful, because in some patients it will be helpful. And finally, last resort is that you can resume the agent, because after a certain amount of time, you have the upregulation of the receptors. If you put that agent back on, you'll again block the dopamine, and technically it's not going to get any worse at that point in time, and actually studies have shown it doesn't. Once you've already developed an established chronic tardive dyskinesia, it doesn't get any worse. So having to put the agent back on, if it's somebody that just can't live otherwise, it might be helpful to them. Finally, these two agents, cholinergic agents and vitamin E, have thought to be potential agents, but all clinical trials so far have shown them to be non-effective. When we talked before, we talked that dopamine also regulates your prolactin pathway. And so if you're blocking, dopamine inhibits prolactin release. So if you block dopamine, you can cause prolactin to be released. And therefore, in essence, you can cause lactation. So for women, you can cause amenorrhea or oligomenorrhea, which is either infrequent or no menesis at all, infertility, and then lactation. And in men, it's usually sexual dysfunction, headache, vision problems, and decreased testosterone and hypogonadism. So in essence, you're affecting the release of sex hormones in the body and disrupting fertility in both men and women with increased prolactin. And management of this is just to decrease the dose of the agent or get rid of it altogether if you can. Consider an alternate agent, again, that has lower dopamine binding affinity. And if somebody has symptoms that are not abating, I don't think they would usually recommend to do this in less severe cases. But you can use bromocriptine, which is a dopamine agonist. So therefore, you could hopefully go back to blocking the prolactin to reverse some of those symptoms. All right, neuroleptic malignant syndrome. This is a severe complication of antipsychotic agent or a dopamine blocking agent. And the main things that you see are hypothermia, rigidity, and then the autonomic dysregulation. We'll go through them a little bit more in a minute. These are the risk factors. Just to save time, I'm not going to read them all to you, but the biggest things are the dose of the antipsychotic that you're using, the potency of the psychotic agent that you're using, and how quickly the dose escalated of that agent to cause those type of syndromes. The others that they see, they've just been seeing clinical research and trials as far as risk factors. These are what are considered potential risk factors, and again, for time, I won't go into them, but these are agents, again, in clinical trials that keep popping up, they're starting to see. So are they really risk factors or just potential things that are going on with patients? They're not really sure at this point in time. So with the neuroleptic malignant syndrome, your hypothalamus is affected. Hypothalamus controls your temperature. So when this is affected and disrupted by dopamine, you have elevated temperatures, and also your body will lose its regulation devices to control the temperature on its own. Peripherally, it'll cause calcium to be released from the sarcoplasmic reticulum, which is basically your skeletal muscles, and more calcium causes them to contract more rigidly. So that's the rigidity and muscle breakdown that will occur. In your sympathetic nervous system, basically this is your flight or fight nervous system, and it removes the inhibition of that. So therefore, your body's just kind of going crazy with the fight or flight. So you'll have everything picked up with your blood pressure, your heart rate. Any system that will be regulated by this will augment and increase. So diagnostic criteria. This is from the Journal of Psychology, I think. And with this, you see you have to have a recent dopamine agent. So just like serotonin, we had to have a serotonergic agent. This one, we have to have a dopamine agent or withdrawal of the dopamine agent recently. Again, you'll see the hypothermia, the rigidity, mental status changes. One of the biggest things that you're going to see is creatine kinase elevation, because when you have muscles that are completely rigid, which in this case they're called lead pipe rigidity, your muscles will begin to break down quickly, and you'll see elevation of the creatine kinase. Like we talked about, your sympathetic nervous system will go completely berserk. Tachycardia, tachypnea will all increase, and also then any other negative diagnostics rule out all other cases. These are the actual critical values that they're looking for, and again, it's that your temperatures starting at least 100.4 on 2 occasions. Like we talked about, the creatinine kinase is high, blood pressure is elevated, and also that it's fluctuating, and also that you have the tachycardia and tachypnea above baseline. Here are all the symptoms. There is a whole host of symptoms that you can see with this, but in essence, it's what we talked about, is that it's causing excitability throughout your body. So with this, you'll see the autonomic are listed kind of at the top. Then you also see the neuromuscular rigidity, dystonia, and then also off to the right-hand side is your CNS type symptoms that you can have delusions, delirium, detachment from reality type symptoms. So management of the neuroleptic malignant syndrome is most important. Get that agent off, just like serotonin. You want to make sure that you discontinue those agents. And then the other piece of this is just going to be supportive therapy. You need to get those temperatures down. You need to make sure that circulation and blood pressure are controlled. And also, again, aggressive fluid resuscitation, because like we talked about, you're having that muscle breakdown. Components of muscle breakdown can hurt your kidneys and cause end-organ failure. So the more fluids you have, the more that will be flushed out of your system. Agents that can help, dantrolene. This one's also used for malignant hypertension that you see with the anesthetic agents. And what it does is it causes your muscles, in essence, to relax, is what this agent will do. Dopamine agonist potentially will be given because what you're doing is you're blocking that dopamine. So if you augment dopamine, you might help to bring the body back under control and not have so much excitation. Final piece is patients potentially are delirious, confused, agitated. Giving them benzodiazepines will decrease that GABA and get that neuroexcitability down in these patients. So reintroduction. Usually all of these patients that if they're reintroduced, you'll see the numbers, it can reoccur in these patients. So you want to be very careful about reintroduction once they have the neuroleptic malignant syndrome. And also if you do start them, try to start them on a different antipsychotic class. If it was a first generation, switch them to second. And if it's atypical, use one of the ones that, again, is lower in its dopamine affinity. So looking at this, it's usually confusing to people whether somebody has serotonin syndrome or the neuroleptic malignant syndrome. This is kind of how you differentiate. And the biggest thing is, did they have a serotonin agent or did they have a dopamine agent? So those are the biggest thing that you're looking at. And serotonin onset is much more quick, and its resolution is more quick. And the difference between the biggest thing is that in serotonin you have those continuous muscle contractions, where in the MS you have less type rigidity. You're just stiff. And also it's happening throughout your whole body, where we said in serotonin syndrome, it's usually in your lower extremities. Next that we wanted to talk about, and I'll kind of go through these quicker.
Hey, Lori?
Yeah.
Can I interrupt for a moment, because I think we've got a pull-in service on metabolic syndrome scheduled with either Dr. O'Malley or Von Rowan, and so you could skip over this one?
Okay, great. And again, this is going to be linked to your antipsychotic agents, I mean your atypical agents. So that's where this is coming from. Adverse effects associated with lithium. This is a whole host of side effects or adverse effects that you can have with lithium. The main ones that I'm going to just focus on today are the hypothyroidism and the polydipsia, or increased thirst and or polyuria, which is increased urine that can be linked to lithium. So hypothyroidism, lithium actually disrupts your iodine uptake and disrupts the amount of T3 and T4 that are released in your system. So therefore it can cause patients to have hypothyroidism. It's not going to happen in all patients. It's probably people that are more sensitive to it, or maybe potentially we're already leaning towards that anyway. But basically what you do in this is that you either decide, is it severe enough that it's problematic, and if it is, potentially remove the agent. If it's not, consider giving them some levothyroxine or Synthroid to augment the hypothyroidism. Lithium diet restrictions. This is basically, lithium is a salt. It is very similar to sodium as a salt. So if you have decreased salt intake through the kidneys and in the body, mainly in your kidneys, it will, if it's missing sodium, it'll absorb more lithium. As lithium doesn't get metabolized, it basically goes straight out your kidneys as the salt. So if your body's low on salt, doesn't see any salt, it's just gonna absorb more lithium instead. So if your salt levels go down, your lithium levels can go up. Next thing for your fluids, as fluid intake goes down, again, the body will try to be reabsorbing water through the kidneys, and as it does that, it might increase lithium reabsorption in your kidneys as well, so your lithium levels go up. And then basically alcohol and caffeine cause you to have dehydration, so the same thing as the fluids. This is a severe example of the polyuria that can happen with lithium. It's a lot of words, but I can explain it a little bit more concisely, is that basically you have antidiuretic hormone, and what this does is it works on aquaporin 2 channels in your kidneys and causes them to want to make water more permeable or more absorbable in your kidneys. And what lithium does is it enters the cells that are working with antidiuretic hormone to cause your body to absorb more water, and it'll disrupt those cells and make antidiuretic hormone not work. Therefore, you're not able to absorb more water, and you pull, or you aren't able to absorb water, so water will flow through your kidneys and you'll have large amounts of urine. So in essence, that's what is happening in this scenario. Also, the lithium can disrupt prostaglandins and make those aquaporin channels not work as well. So again, you're not absorbing as much water, so you have large amounts of urine. So on a small scale, you might just see a patient have a little bit more urine or a little bit polyuria. This is an extreme example, but it's still the same thought process by what is happening. So does that make sense? And this is just a diagram type example. Basically where the antidiuretic hormone is working is in the collecting duct, and mainly your lithium reabsorption is the proximal tubule. So when you have this disruption, you won't be able to absorb all the water that's funneling out to your bladder in the collecting ducts, and that's why you see this disruption. So management is to decrease your dose of lithium or stop, depending on how severe, and then just make sure that they're managing their salt and fluid intake. Another piece that you can do is using the thiazide diuretics, and what this does is it promotes absorption of water higher up in that proximal tubule on the very top left. So water will be absorbed there, where your lithium is disrupting the collecting duct, so therefore you get water reabsorbed before it gets to the problem area, and you can help decrease the amount of polyuria that the patient is having. The final piece of this is that also they can use indomethacin in severe cases, because we did say that the prostaglandins can be disruptive and disrupt that aquaporin channel, and therefore you can't absorb as much water. What the NSAIDs will do is inhibit that and basically cause more water to be absorbed, and also it can decrease your just whole filtration rate, and therefore you might absorb more water as well.
And we know this is happening because of their complaints of frequent voiding?
Yeah, that would probably be,
Or less.
they will tell you that they feel thirsty, that they have to go to the bathroom all the time, so those would be the complaints that you'll usually see. Final one that we'll just touch on real quickly is Stevens-Johnson syndrome. And in essence, what this is a huge allergic reaction to an agent, and it's usually considered idiopathic. They don't really have an understanding or an idea why this is truly happening. It's just that it's happening in the skin, and it's a large allergic reaction to something that's going on in the body. Potentially, we have a whole host of meds that we'll list here. Stevens-Johnson syndrome is actually a minor form of the toxic epidermal necrolysis. So as you see here, it just moves between the two depending on how much body surface area is being affected. So in essence, they're the same thing. It's just how much of the body is being affected by the skin disruption. So causes are infection, drug-induced, probably most common, and malignancy related is another, and idiopathic, and 25 to 50% of cases are idiopathic. So it's kind of scary that we don't always know the cause of what's happening. These are the agents that are most noted. Again, it's kind of like the serotonin syndrome. This is the start of a list, but it's not all inclusive. Anything potentially could be causing someone to have an allergic reaction that could cause Stevens-Johnson syndrome, but these are probably the most noted agents that we see. So as far as presentation, in the first 1 to 2 weeks, you'll see that patients almost look like they have kind of a mild, like flu-like symptoms. And after 2 to 4 weeks, they'll start to experience rashes on their face and torso, and then they'll start to develop oral mucosa or genital lesions that start to develop. They're non-itchy at first, so that's something to remember if you have somebody start to tell you that they have a rash that's not itching, something to just keep in the back of your head. Ocular symptoms is that they start to feel redness, tearing, grittiness, double vision, dry eyes might be noted along with the rash. As this rash begins to develop, it basically goes from macules, which is little skin spots that are reddening. They're not elevated, just you see spots. Then to papules, which are like a hive that's a round bump that's elevated, but it's small. And then to vesicles, which is a blister. And then to, I don't even know if I'm saying this right because I'm not dermatology based, but bulbae, or bullae, which is clusters of blisters. And then urticarial plaques, which are like hive-like plaques. And then also, basically that means continuous reddening throughout the skin as well. So the center of these lesions will look like blisters or be purpuric, which means that they are red, purplish looking. That means that they have blood in them, as like small little hemorrhages, and they might become necrotic. And a lot of times they have the appearance of like a target, is how it is described in the literature. So the lesions will just continue to become more blister-like throughout their skin, depending on the severity, like from 10 to 30% of where it's serotonin syndrome to the toxic epidermal. The skin will just rupture and become denuded, which in essence what is happening is you have 2 layers of your skin. You have the epidermal layer on the top and the dermis on the bottom. As the blisters begin to pop, they'll slough off and you'll lose your epidermal layer and just leave your dermal layer. So you actually are losing your skin in these scenarios.
Sorry, that's my phone.
Over there.
So management is basically you need to get, if you know of an agent that the patient has taken, get it off as soon as you can. And then what these patients, what they do with them is they basically put them in burn units if one is available, and treat them like burn patients, because in essence they're losing their skin like a patient would that's been burned. So you're doing basically supportive therapy in these patients, and biggest thing for them, as you can imagine, the reason you have skin, it's your protective layer. If you lose your skin, you are open to infection, and probably I think the 30 to 40% mortality that happens with severe Stevens-Johnson syndrome is from sepsis. So a lot of people will die from sepsis. So it's pretty scary once it gets started, so something to really watch for with these patients. And then the other thing is they're going to have huge amounts of pain. When you are a burn type patient, your body is in a catabolic state, so therefore they need huge amounts of nutrition. So they're probably going to be put on the total parenteral nutrition at huge doses to keep up with the protein needs that they need to rebuild their skin and just to heal themselves. And then the other agents there, this is thought to be an immune response of some sort. So they're looking into and doing research on IVIG, immunosuppressants, and steroids. But it's all very controversial at this point in time. So. Anybody have any questions? That's all I have for you today.
Wow, that was great.
Yeah.
Thanks.